Hello, I'm Kevin Fernando, a GP working near Edinburgh in Scotland and content advisor for Medscape Global and UK. Welcome to our podcast, Medical Mentor, a bite-sized regular chat for all of us working in primary care. Podcasts will cover hot topics, practice pearls and hacks, as well as pitfalls to avoid, helping make our lives a little bit easier in primary care, but ultimately to help improve the lives of our patients. In this podcast, I'm going to give an update on SGLT2 inhibitors, which I reckon are the biggest therapeutic advance in my career to date. I've been prescribing SGLT2 inhibitors for over 10 years now in primary care, and during that time, prescribing indications for SGLT2 inhibitors have significantly expanded beyond their original use for glycemic management in type 2 diabetes, driven by a rapidly evolving and high-quality evidence base. SGLT2 inhibitors are now indicated for atherosclerotic cardiovascular disease risk reduction for those with type 2 diabetes, all subtypes of heart failure, HFrEF, heart failure with reduced ejection fraction, and HFpEF, heart failure with preserved ejection fraction, as well as chronic kidney disease in people with and indeed without type 2 diabetes. In my opinion, SGLT2 inhibitors are now the new standard of care for cardiovascular, renal, and metabolic protection in people living with type 2 diabetes, and we should consider them as primary and secondary prevention agents independent of their glucose-lowering benefits. Similar to how we all in primary care consider a statin for anyone living with type 2 diabetes at increased cardiorenal risk, we should also consider starting an SGLT2 inhibitor for all with type 2 diabetes at increased cardiorenal risk. Multiple recently updated guidelines across the world have reflected this shift from a glucose-centric approach to the management of type 2 diabetes to thinking beyond glycemia and identifying significant comorbidities alongside type 2 diabetes, such as atherosclerotic cardiovascular disease, all subtypes of heart failure, and chronic kidney disease, and using these comorbidities to guide choice of therapy independent of glucose control. Now, of course, I'm not suggesting that good glucose control is no longer important. Good glucose control protects against the microvascular complications of diabetes, but good glucose control only has a modest impact on the macrovascular complications of diabetes, which often have a bigger impact on quality and quantity of life. Now, recently updated United Kingdom NICE guidelines for type 2 diabetes remind us to assess HbA1c, cardiovascular risk, and kidney function in all people living with type 2 diabetes. For those with a background of all subtypes of heart failure or established atherosclerotic cardiovascular disease, it is recommended to offer metformin, and as soon as that metformin is well tolerated, we should offer an SGLT2 inhibitor with proven cardiovascular benefit, independent of glucose control. That is to say, even if that individual's HbA1c is within their target range. Moreover, if that person living with type 2 diabetes has a 10-year cardiovascular risk of greater or equal to 10%, we should do the same. Start metformin, and as soon as that metformin is well tolerated, add in an SGLT2 inhibitor with proven cardiovascular benefit, independent of glucose control. Furthermore, recently updated United Kingdom Kidney Association guidelines for SGLT2 inhibitor use in adults with kidney disease gives grade 1A recommendations for SGLT2 inhibitor initiation in people living with type 2 diabetes with an EGFR of 20 to 45 mils per minute or an EGFR over 45 mils per minute with a urinary ACR greater or equal to 25 milligrams per millimole. And again, we should be initiating the SGLT2 inhibitor in this context independent of glucose control, even if HbA1c is within target range. Now, the UK Kidney Association guideline does remind us that as we are now initiating SGLT2 inhibitors at lower and lower eGFRs, we must be mindful that all SGLT2 inhibitors have negligible glucose-lowering effects once eGFR drops below 45 mils per minute. So we should still start an SGLT2 inhibitor for renal protection, but if we need additional glucose-lowering benefit and eGFR is less than 45 mils per minute, we should consider an additional glucose-lowering drug. Additionally, there is no need to routinely check kidney function after initiation of an SGLT2 inhibitor. A dip in eGFR is to be expected due to a reduction in interglomerular pressure, and checking renal function too early may inadvertently present a hurdle to continuing SGLT2 therapy. Now, beyond the UK, the ESC, the European Society of Cardiology, have recently published guidelines for the management of cardiovascular disease in patients with diabetes, and KDIGO, Kidney Disease Improving Global Outcomes, have also produced guidelines for diabetes management in CKD. And both of these guidelines provide similar high-grade recommendations with respect to initiation of SGLT2 inhibitors independent of glucose control. Now, I appreciate I've been waxing lyrical about SGLT2 inhibitors, but no drug is without harm. Paracelsus was a Swiss-German Renaissance physician and the founder of the discipline of toxicology. He famously said that poison is in everything and no thing is without poison. The dosage makes it either a poison or a remedy. So what are the key side effects of SGLT2 inhibitors that we need to be aware of in primary care? Well, during my 10 years plus experience of prescribing SGLT2 inhibitors, the commonest side effects I've encountered are mycotic genital infections. So counseling about good personal hygiene is pivotal. If individuals do develop troublesome mycotic genital infections, they can be treated in the usual manner and tend not to recur. Initially, urinary tract infections were thought to be a challenge, but actually that hasn't been borne out in clinical studies or indeed my own clinical experience. However, if individuals do develop urinary tract infections, again, they can be treated in the usual manner and tend not to recur. We should also reinforce the importance of adequate hydration to prevent volume depletion. I usually recommend around 2 to 2.5 liters of clear fluids daily, not including tea, coffee, or alcohol. Other osmotic symptoms such as thirst, polyuria, lightheadedness, and fatigue can also occur, but usually dissipate with time. An adverse effect of note, though, is a rare association with diabetic ketoacidosis, DKA, around 1 in 1,000 or 1 in 10,000 risk. However, the benefits do outweigh this risk. The challenge is that the DKA we sometimes see with SGLT2 inhibitor use is euglycemic DKA. Blood glucose levels are normal or near normal. So how do we make sense of this in primary care? We need to warn individuals of the signs and symptoms of DKA, which is quite challenging as DKA presents very non-specifically. However, I tell my patients if you're significantly unwell, especially with a fever, you should get in touch for further assessment. We need to assess that individuals, we should check blood glucose levels, and if we suspect DKA, we should test for blood ketones, even if blood glucose levels are normal or near normal because of the possible euglycemic nature of the DKA. Now, importantly, there's no need to issue ketone testing strips to those on SGLT2 inhibitors, but we should have access to them in our respective clinical practices. As such, SGLT2 inhibitors should add to our ever-expanding list of sick day guidance drugs to temporarily pause during any acute, potentially dehydrating illness. A useful mnemonic is SAD man, we should counsel patients to temporarily pause the sad man drugs during any acute dehydrating illness. S for SGLT2 inhibitor, A for ACE inhibitor, D for diuretic, M for metformin, A for ARB, and N for non-steroidal. And importantly, we need to remind individuals to restart these drugs once they're eating and drinking normally and recovered from their illness. Finally, there's a very rare association between SGLT2 inhibitor use and Forus Gangri, or necrotizing fasciitis of the genitalia or perineum, which is challenging to quantify. I've never seen this with respect to SGLT2 inhibitors during my career to date, and an important confounder is that type 2 diabetes itself is a risk factor for Forus Gangri. Moreover, there was no significant imbalance seen in cases of Forus Gangri in all major SGLT2 inhibitor trials to date. So how do we make sense of this in primary care? I've got to be honest, I don't explicitly mention Forus Gangri, as I think this would present a huge barrier to starting or continuing therapy. However, I do reinforce the importance of good personal hygiene and advise individuals taking SGLT2 inhibitors to seek urgent medical attention if they experience any severe pain, tenderness, erythema, or swelling in the genital or perineal area, particularly if accompanied by a fever or malaise. So to finish, some resources you might find helpful. I've created several concise patient-facing videos on YouTube and TikTok about SGLT2 inhibitors to help inform, educate, and counsel our patients about all aspects of their SGLT2 therapy, including benefits, side effects, and sick day and driving guidance. You can find me at Dr. Kevin Fernando on YouTube and TikTok. Additionally, I've produced a Medscape UK primary care hack or clinical aid memoir on the extra glycemic indications of SGLT2 inhibitors aimed at healthcare professionals, which can be found at medscape-uk.co/hack-SGLT2I. I hope you find these resources helpful. So thank you all for listening. I hope you found this podcast helpful. Please do listen to our future Medical Mentor podcast, which will be available on all major platforms. Follow me on X, formerly Twitter, at Dr. Kevin Fernando, or email me on kfernando@webmd.net if you have any questions, comments, or ideas for future podcasts. Thank you again for listening.